Hi everyone. Good evening everyone. So are my slide visible?
Yes.
Okay.
Yes, sir.
So good evening everyone. So I thank the organization, especially Dr. Akash Tiwari, for giving the opportunity. So I will be the opening batsman for this program. So topic I am going to discuss today is the new treatment approaches in the management of HER2 positive metastatic breast cancer, and specifically I believe talking about the role of pertuzumab in the metastatic breast cancer. As we all know, whenever we see a patient of metastatic breast cancer, we do the testing for after the staging work of ERP or HER2, and based upon we decide the treatment protocol for that patient. And we know when the patient has a HER2 overexpression either by the ISC or by FISH testing, it indicates a bad biology, that aggressive biology, because the HER2 positive is associated with the more disease recurrence, extensive disease burden, short-term survival, rapid tumor development, high nuclear grade, and around 20% in our practice patient are HER2 positive. So HER2 overexpression is associated with bad biology and the bad outcome before the invent of trastuzumab pertuzumab, and they were need to address this unmet need, how to overcome that bad biology. As we can see here, when there is a HER2 gene amplification, it is associated with the less tumor response to the chemotherapy, and there is a decreased survival with the HER2 amplification also. So the first drug that we have to target the HER2 amplification was back in 2001, I think. So the first drug was trastuzumab that was tested in metastatic breast cancer. The standard of care at that time was chemotherapy. So chemotherapy, there were two group chemotherapy with the plus the trastuzumab, and with the addition of chemotherapy, the response increased from 20 months to 25 months. That was approximately 5-month increase in survival, and around hazard ratio of 0.8. So 20% reduction in the risk of death with the addition of trastuzumab. But still, many of these patients, they are not surviving very longer. So the response and duration response were still less that we expected in the stage 4 cancer, and the duration, most of the patients, around 50%, they progress within 1 year only. So depth of response was less with the addition of trastuzumab. So there was need to add more or to change more so that we can improve the outcome of this patient. For many years, we have this combination only, the trastuzumab and with the chemotherapy only. But the scenario changed with the addition of pertuzumab in the metastatic breast cancer. So as of now, although as of today, this slide may look outdated, but maybe 2 years back. So this is the algorithm that we follow for the HER2 positive metastatic breast cancer when we see patient of stage 4 metastatic breast cancer patient. First line treatment, the trastuzumab, pertuzumab, and taxane. When they fail, then the TDM1. Nowadays it will be TDXD, and then third line will be HER2 directed therapy, either lapatinib or trastuzumab with the addition of chemotherapy. If the recurrence is within 6 months only, that will be rapid progression, then the pertuzumab is not indicated in that setting with the combination of trastuzumab. Then the first option will be TDM1 or nowadays TDXD. Then the second line HER2 with chemotherapy, and then fourth line HER2 and chemotherapy, either lapatinib with combination with capecitabine or trastuzumab and any other drug if available, like tucatinib and other drug. So what is the role of pertuzumab? Why it is indicated in the first line combination with the addition of trastuzumab in combination with chemotherapy? So pertuzumab, as we know, it acts on the HER2 amplification, but the domain binding site is different compared to the trastuzumab. The trastuzumab bind to the subdomain 4 near to the juxtamembrane region of the HER2 region, but the pertuzumab bind to the domain 2. So it basically prevents the dimerization of the HER2 with the HER3 and HER4, and so by inhibiting dimerization, it inhibits the downstream signaling. So that basically decrease the cell growth and that causes cell kill the cell. So it was first tested in a phase 3 trial, that is the Cleopatra trial, that is the clinical evaluation of pertuzumab and trastuzumab with taxane. So the trial design was very simple. The patient with HER2 positive metastatic breast cancer were randomized to 1:1 ratio of either placebo with trastuzumab, with chemotherapy given was docetaxel, or with the addition of pertuzumab. The number of cycles the doxycycline were allowed were more than 6 cycles if the patient can tolerate, or if the minimum 6 cycles were allowed. Like the prostate cancer stage 4, if the patient can tolerate 7, 8, 9 cycles, so it was the patient can go on for the can take the docetaxel and number of cycles. The primary endpoint was the independent assessed PFS, and the secondary endpoint was investigator assessed PFS, OS, and the overall response rate. So we have seen the result in 2012, 14, 18, and the 8-year update also of this Cleopatra trial. So the first interim analysis came in 2011. So when they report the overall survival, the second result came in 2012 for the OS data, and for February 2014 the final OS came, and in the November 2018 the result were updated for the end of the study analysis. So we will discuss later in the upcoming slide. So what were these results for the Cleopatra trial? So for the first interim analysis, the primary analysis, that was the PFS for the independent assessed PFS, with the addition of pertuzumab, the progression-free survival increased from 12.4 months to 18.5 months. That was the 6-month increase in the PFS with the addition of pertuzumab. The curve starts separating very early, that is the 3 to 4 months only, and they remain separated throughout the course of the trial. The overall survival with the addition of pertuzumab, the PFS was at the first analysis of 56.5 months compared to the control of 48 months. That is the 16-month gain in the overall survival. And the end of the study landmark at the 8th year, that the OS was 37% in the pertuzumab arm with the median follow-up of 19.9 months. What is fascinating is in a stage 4 breast cancer, any stage 4 cancer, we are talking about the OS data of 8 years. That means in the adjuvant setting also, when we see the patient is survived 5 years, we say they are cured. Now here in the stage 4 cancer, there are some around 35% patients, they are still alive at the end of 8 years. That is very remarkable. The benefit is provided by the addition of the pertuzumab, trastuzumab, docetaxel, and the subsequent line, but still in the stage 4, that is very remarkable. The safety profile of the combination of pertuzumab and the trastuzumab, the cardiac safety, they were well maintained at the 8-year follow-up also. So we have a very mature data of 8 years with the addition of the pertuzumab and trastuzumab with the docetaxel. So in the final overall OS analysis that was done at the 8 year. So with the addition of pertuzumab, there was a 15.7 month median gain in overall survival with the addition of pertuzumab. Also, for the final PFS analysis that we seen earlier, the first interim analysis, that was 6.3 month gain in the PFS with the addition of the pertuzumab. The hazard ratio 0.68 with the addition of pertuzumab. So these are the survival. So 1 year, almost same comparable, around 90% patient alive at the end of 1 year, and then the difference keep increasing with the longer follow-up, and we can say 5 years, 6 years, 7 and 8 years, 23% in the control arm and 37% in the experimental arm, that is with the addition of pertuzumab. And that is despite that the crossover was allowed, that the patient in the control arm who have progressed, they were allowed to take the pertuzumab despite taking the crossover, and despite those patients in the control arm, they were included into the intention to treat analysis. This overall survival advantage remain persistent across a longer follow-up of 8 years. So that we have seen earlier. So 8-year OS 37% versus 23 year. That is the difference of around 15%. That is very remarkable in any cancer, that is stage 4 cancer. And 15% patients more are alive with the addition of the drug, that is the pertuzumab. So whenever we treat a stage 4 cancer, not only the PFS OS matter, the response rate and the rapidity of response also matter, because the response, rapid the response and the more durable the response, that means the more better the quality of life. So with the addition of pertuzumab, in the control arm, the response rate was 70%, and with the addition of pertuzumab, it increased to 80%. It was a 10% increase in the response rate. So that means the more better quality of life for the patient. And the duration of response, that means the how long the drug is working, that was also better with the addition of pertuzumab in the first line. So it was a gain of 7.7 months with the addition of pertuzumab in the duration of response. So there were some subgroup analysis, although they were not pre-specified in the clinical trial. So, but they were exploratory. But say the analysis were done based on the hormone status, the prior treatment that they have taken at the pertuzumab in the adjuvant neoadjuvant setting, the site of metastasis, CNS disease, or the age subgroup. So the hormonal status, because we know, because many of these patients, they are ERPR, the HER2, so that is the HR positive. So on the OS and the PS, so either they are ERPR positive or negative. So the OS benefit was seen, and the OS benefit was seen irrespective of they were ERPR positive or negative. The hazard ratio almost 0.7, 0.6, 0.73, 0.64. That means the HR receptor status doesn't matter with the addition of pertuzumab. Both groups benefit with the addition of pertuzumab. And although that is somewhat surprising that we don't do practice, that is the non-concurrent hormone therapy was allowed before the disease progression. Many of the time what we see, and most of the what we follow is, whenever we finish, the patient has finished the chemotherapy, the docetaxel, and when they go on to maintenance pertuzumab, we add the hormone therapy. But in this clinical trial, that was not added till the time the disease has progressed. So in the treatment the EBC, so early breast cancer, the patient has received without neoadjuvant chemotherapy, the ratio 0.66. Even if they have received the neoadjuvant therapy earlier, it was 0.66, and patient with the neoadjuvant therapy with the trastuzumab. So it was still all this subgroup, they benefit from the addition of the pertuzumab. Same with the PFS, either they receive the trastuzumab in the neoadjuvant setting or adjuvant setting, they still benefit from the hazard ratio 0.6, 0.6 with the addition of pertuzumab. So as we all know, during a course of the HER2 positive, many of these patients they do develop the CNS metastasis, and with the addition of pertuzumab, so median time to progression of CNS metastasis was less with the addition of pertuzumab compared to the experimental arm, control arm, sorry. And sometime what happens is, and we have seen with the many of the other cancer, so when the age group is like more than 65 or 70, so those patients, they don't get benefit from the whatever the new drug has been tested. So but in this Cleopatra trial, either the age was less than 65 year or more than 65 year, both this patient group, they get benefit from with the addition of pertuzumab. So more than 65 response rate even better with the pertuzumab, 84% with the 70 compared to 70%, less than 65, 60 versus 79. So that means both the response rate was same irrespective of the age, or less than 65, more than 65. So Perjeta, that with the addition of pertuzumab in the first line, it is when we add the new drug, so we have the option of how to adjust the dose of the pertuzumab, what will the new side effect, and how, because the pertuzumab, like it is like a trastuzumab target the HER2, there may be more cardiac safety. So what were the impact of these three outcomes in this clinical trial? So the long-term safety and cardiac safety profile of with the addition of pertuzumab were maintaining the overall and crossover population. Overall means the experimental arm, and crossover means the patient who has taken the pertuzumab after the progression in the control arm. So with the addition of the pertuzumab, diarrhea is more compared to the control arm. As we all know, the diarrhea grade 3 was 5% in the HT arm and around 10% in the pertuzumab arm. But in our clinical practice, we know that it can be managed with the antidiarrheal drug like the loperamide. RAS slightly more with the addition of pertuzumab, 1.3 grade 3 versus 3.74. The liver, the LV dysfunction based on the 2D echo and any other modality, it was more or less same. So the grade, so it was same in both the arm. Grade 3, 3.3 versus even it was less with the addition of pertuzumab. So cardiac safety more or less same, but the diarrhea and RAS were more with the addition of pertuzumab. And so, yeah, and when we add because the chemotherapy arm, so number of cycle of docetaxel taken was similar in the both the arm, 8 cycle. Dose intensity was more or less same, and dose escalation in our clinical practice, we normally don't start with rarely we go up to 100 mg per meter square. So generally we start with 75 and maybe we have to decrease to 65. But in this trial, so around 15% patient can go up to the 100 mg per meter square. So with the addition of docetaxel, because we know there will be alopecia, diarrhea, myalgia, nausea. So, but these side effects with the addition of the pertuzumab were more or less similar in both the. Also, with the addition of pertuzumab, the age, because when the age is more than 65, the older age patient, they have the they may develop more serious side effect, grade 3 and grade 4. But the common side effect that we see with the addition of docetaxel and with the addition of pertuzumab, the alopecia, diarrhea, the neutropenia, nausea, and the neutropenia, they were more or less similar in both the arms. So these are the grade 3 and 4 side effect. They were similar in both the arms. So the cardiac safety wise, there is apprehension, because when we add the second drug that can decrease the left ventricle dysfunction, that can cause left LV dysfunction. So with the addition of pertuzumab, so there were no cardiac safety signal. So so basically, so it was 3 point grade. So the patient with reduction in LVF by more than 10% and less than from the baseline and into less than 50% was 3.3 in the control arm. Compared to the pertuzumab, it was only the 1.5%. So basically, the addition of pertuzumab doesn't cause the new cardiac signal, doesn't cause the decrease in LV ejection fraction. And as we all know, so these decrease in LV ejection fraction, they are reversible. So most of the patients, like the 90%, of the patient recover to normal LVF after stopping the pertuzumab and the trastuzumab. So basically, all the major body all over the world, either the NCM, NASCO, the ESMO, they recommend the pertuzumab in the first line in the HER2 positive metastatic breast cancer. And we all know the ESMO, basically they have a more stringent criteria to approve a drug in their setting. So they analyze many factors like the cost effectiveness, the cost, how much burden it costs to their healthcare system. So they have given a rating of the 4, the maximum is 5. So 4 rating means that means they highly recommend this new standard of care to the effective treatment. So dose wise, we know, so the flat dose is not based upon the per kilogram dose like the trastuzumab. So pertuzumab, the flat loading dose is 840 mg, and then you can then the subsequent dose will be to 420 mg for the in combination with the trastuzumab. And whenever there is a more than 6 week gap is there, maybe mostly because of the decrease in LV injection fraction, then you have to again give the loading dose and then continue with the maintenance dose. If the gap is less than 6 weeks, you can still continue with the loading maintenance dose of 420 mg. Like it is same with the trastuzumab, and the same with the pertuzumab. For the trastuzumab also, if the gap is more than 6 weeks, we have to give the loading dose of 8 mg per kg. And the cardiac monitoring safety, because every 3 months we have to do the 2D echo, and these are guidelines similar for the trastuzumab when we have to stop the pertuzumab. That means there is a fall ejection fraction less than decrease to 50% with a fall of more than 10% from the baseline. Then we have to stop the drug. Then and do the monitoring subsequently, and when it recover, we can again restart the drug. So to summarize, the unprecedented significant OS improvement with the pertuzumab, trastuzumab, docetaxel compared with the docetaxel, trastuzumab, the first line MBC, observed at the final OS analysis were maintained at more than 8-year follow-up. That means there were consistent benefits seen all over a longer period of 8 months. Median 48.1 OS with the control arm versus the 57.1 month with the experimental arm. There was a 16.3 month gain in the overall survival. And the investigator's PFS effect was maintained with the hazard ratio of 0.65. Safety profile is consistent with all the subgroup, that either the HR positive age less than 60, more than 60, the CNS mets and the other group. The long-term cardiac safety was maintained at the end of study analysis. And the longest follow-up for patient for the first line treatment of HER2 positive metastatic breast cancer, that is a 120-month follow-up now we have with the pertuzumab. And still, I can say in 2022 in March, the pertuzumab, trastuzumab, docetaxel remain the standard of care for the patients who are not been previously treated with the HER2 positive metastatic breast cancer. Thank you.
Thank you, sir, for a wonderful talk. Sir, it is just strange. We usually use hormonal therapy with the maintenance Perjeta trastuzumab. Do you see a particular reason that it was not used on the trial, or?
So I was going through the method, but I think it was not mentioned. I don't know. So because maybe what was he thinking? So usually we do when we stop the docetaxel, we start on the hormone treatment. So I think that will be logical sense, because we use this in the adjuvant setting. So I think no reason that I can say why it was not used.
Thanks, sir. Thanks for the wonderful talk.